You're worried about sexual side effects, but you also want to keep your hair. So what's the real risk? I'm Dr. Eric Ko, a hair transplant surgeon in Seoul. Today, I'll give you clear numbers on sexual side effects from finasteride and dutasteride. And I'll explain what I actually do in clinic to minimize risk. We'll also answer 3 side questions I get every week. 1. Is baldness from mom or dad? 2. Does lifting or creatine make hair loss worse? 3. And should you start medication early? Remember, this is education, not personal medical advice. You should talk to your own doctor about your case. Let's start with the question that stops a lot of men from getting treated. What is the actual probability of sexual side effects? From controlled clinical trials on finasteride 1 mg, sexual adverse events are reported in about 1.8 to 3.8% of men, only slightly above placebo. And here's a crucial detail. With long-term use, those rates drop. The FDA label notes the incidence of each sexual adverse event decreased to less than 0.3% by year 5. And most cases resolved even if patients continue therapy. With dutasteride 0.5 mg, there's a well-run randomized trial where sexual adverse events were up to 4% versus up to 2% on placebo in the first 3 months. But the incidence fell to about 1% later. Events were mild to moderate and typically resolved. The onset clustered early, which matches what we see clinically. Those are trials, and they're important. But what happens in the real world over years? A South Korean multi-center chart review followed men long-term and found sexual adverse events were rare. 1.6% on dutasteride and 1.1% on finasteride. Decreased libido being most common and erectile dysfunction under 1%. Therefore, in daily practice, the risk often looks closer to 1 to 2% rather than double digits. Now, we must discuss less common but important concerns. It is about persistent erectile dysfunction. A large observational study reported 1.4% of men exposed to finasteride or dutasteride developed erectile dysfunction persisting more than 90 days after stopping, and longer exposure correlated with higher risk. This is not common, and patients do recover eventually, but it is documented. Therefore, duration and follow-up matter. Next one is post-finasteride syndrome. The definition and causality are debated. Some papers and patient groups describe persistent sexual and neuropsychiatric symptoms after discontinuation. Evidence is mixed, but I take it seriously in screening and monitoring discussions. That is why I encourage all my patients to talk to me if they experience sexual adverse effect. Stop early. No post-finasteride syndrome occurs. One more regulatory update you should know. In May 2025, the European Medicines Agency confirmed suicidal ideation as a listed side effect for finasteride, 1 mg and 5 mg. Frequency is unknown. The overall benefit risk remains positive, but we should therefore screen for mood changes and act early if concerns arise. My clinic protocol is simple and structured. 1. Baseline sexual health and mood screen. Shared decision on dose and formulation, oral versus topical, because physiology and preferences differ. Start standard dose or lower for sensitive patients, and schedule a 2 to 4 week check-in. If issues appear, we adjust. Dose spacing, switch to topical finasteride, consider alternative strategies, or pause. We reassess benefits versus risk at each visit because goals change, but your health comes first. So the bottom line is that the average man's risk is low and typically transient, but rare persistent outcomes have been reported. Therefore, informed consent and follow-up are essential. People love the myth that baldness only comes from mom's side is catchy, but it's wrong. Male pattern hair loss is polygenic. The X-linked AR region matters, and so do many autosomal loci identified by large genome-wide association study. Therefore, risk can come from either parent, and polygenic score performance even varies across ancestries. Clinical takeaway is to check both sides of the family and look at age of onset and pattern, not just one uncle. Now let's tackle a myth I hear from a lot of younger patients. Doctor, am I making my hair fall out because I lift weights or because I take creatine? Strength training does temporarily raise testosterone and even DHT levels, but these spikes are small and short-lived. They usually return to baseline within an hour or two. That's not the same as having chronically high DHT levels, which is what actually drives follicle miniaturization in androgenetic alopecia. And here's the key evidence. In 2025, a randomized controlled trial specifically measured hormones and hair parameters in men, taking creatine versus placebo. The results? No increase in DHT, no negative changes in hair density or thickness, and no creatine-specific effect compared to placebo. This trial confirmed what earlier smaller studies suggested. The fear that creatine accelerates baldness simply isn't supported by data. So what does that mean practically? If you're lifting weights, you're improving muscle mass, bone health, metabolism, mood, and even long-term cardiovascular health. These are huge benefits. But your hair follicles don't suddenly shrink every time you do a bench press or drink a creatine shake. Therefore, the advice I give is this. Keep training for your overall health and confidence, because those benefits are enormous and evidence-based. And if you are genetically prone to hair loss, the right approach is not to stop lifting, but to treat androgenetic alopecia with targeted therapy, whether that's medication, PRP, or eventually surgery. You get the best of both worlds, strong body and protected hair. Hair loss is progressive. Miniaturized follicles don't magically re-expand on their own, but when you intervene earlier, you maintain more hair for longer. The 5-year finasteride data show sustained improvement and slowed progression when treatment is maintained. Therefore, when miniaturization is visible, or when early thinning is objectively documented, I encourage starting sooner rather than later, assuming you're an appropriate candidate. Guidelines and consensus statements consistently position finasteride and minoxidil as evidence-based first-line options in male AGA, and they emphasize ongoing monitoring and shared decision-making. Therefore, your plan should be individualized, trackable, and adaptable. Here's how I synthesize this for patients. 1. If you're risk-averse, we can start low, therefore lowering the chance of early side effects, and escalate as tolerated. If you've had prior sensitivity, we can consider topical finasteride or dose spacing. It's not magic, but it's practical for many. 3. If you're on the fence, we can do a time-limited trial with structured follow-up. If benefits appear and you feel fine, continue. If not, we pivot. If your loss is advanced, medication helps but won't recreate density everywhere. Therefore, surgery may be the definitive solution, with medication as the maintenance engine. My philosophy is being conservative where it matters, aggressive where it counts, and always data-driven. Let's do the recap. Sexual side effects are possible but uncommon and often reversible. Persistent problems are rare but must be monitored. Genetics are shared. Weightlifting is fine. Earlier treatment protects more hair. Now, if you want a personalized plan or a second opinion in Korea, let me know. I can evaluate your case. Thank you for watching.